Imagine this. You're a physician in the US Army and you find yourself on the battlefield in a high-stakes situation. You're faced with two patients, a soldier with a moderate, non-life-threatening infection and a soldier with a severe, life-threatening infection. The moderate soldier can easily be brought back to the fighting force with your penicillin, but the severe soldier can only be made stable with the penicillin and cannot immediately return back to the fighting force without further care. The catch is, you only have enough penicillin for one. The war is intense, and the military needs all the fighters it can get ASAP, placing additional pressure on you. Who do you give it to? Do you get the moderate soldier back into the fighting force, or do you nurse the severe soldier back to stable condition? What should you do? This is an example of the issue of dual loyalties in military medicine. It's a subset of military medical ethics and can be defined as situations in which health professionals are obligated to fulfill multiple roles, resulting in ethical tensions between the roles. In the case of military physicians, this occurs when they are unable to fulfill their obligations toward a patient as purely a doctor, because their military reasons demand to be upheld, sometimes to a higher extent than medical ones. This issue stems from the conflict of interest between medicine and military. Before they begin practicing, all doctors pledge to the Hippocratic Oath, basically stating to do no harm and provide the best objective care to each and every patient. However, if they are military physicians, they then have to pledge to the Military Oath, which dedicates itself to serving the greater good. Now, these oaths are obviously conflicting. Serving the greater good doesn't always mean serving each and every patient the same. This highlights the key difference between the two ideologies. While medicine is focused on obligations to the individual and the patient is the priority, the military is focused on obligations to the greater good, also known as utilitarianism, and the mission is the priority. There are multiple different viewpoints of dealing with this issue. First, the role-specific ethic, proposed by ethicist Edmund Howe, suggests that it is threefold and dependent on the situation. Military physicians should, number 1, exercise no discretion when military demands are substantial, and they should be absolute. Number 2, use their discretion when military demands are considered reduced. Number 3, focus entirely on the individual patient when military demands are negligible. The issue with this viewpoint is that it is relatively subjective, and the detailed bioethical training required for this critical skill is not readily available to military physicians. Without this training, how are military physicians supposed to differentiate when military demand is considered substantial, reduced, or negligible? Another viewpoint is from the World Health Organization, emphasizing the superiority of medical morality. They say simply, medical ethics in the military are identical to those during peace. There is no dilemma. Essentially, they say the physician must always prioritize the patient and never the military. As nice as it would be to be able to follow this view, it is slightly impractical. The military values obedience and loyalty, and if a military doctor was sticking to their own discretion and ignoring orders, they will most likely face severe consequences. The issue of dual loyalties manifests itself in multiple different situations. In regard to the earlier situation with the two soldiers, a medical perspective would see the case much differently than a military perspective. In terms of medicine, a doctor would most likely administer the penicillin to the soldier with the life-threatening condition and simply take measures to prevent further infection for the other soldier until help arrives. However, in a military context, where there's an immediate shortage of soldiers and help is needed ASAP, the military physician would be forced to administer the penicillin to the soldier with a non-threatening condition to quickly bring him back to the battlefield, despite what his medical training indicates. Now, dealing with the soldier in life-threatening condition, the physician needs to consider the use of battlefield euthanasia if they cannot be evacuated, bringing up a whole nother ethical debate. We also see this issue in return-to-duty situations. For example, imagine a soldier was just injured in a bomb blast. After about 6 weeks of treatment, the soldier is medically stable and functional, but he stands at higher risk of severe impairment and PTSD if he was to be involved in another blast. He says, "Put me back in, my buddies need me." But you suspect the strong pressure from chain of command and military stigma against mental health issues are influencing his choice. What should you do? Well, from a medical perspective, you shouldn't sign him off because you know it's bad for his personal health. But from a military perspective, you should sign him off so he can serve in the war for the greater good, regardless of the effects on his health. You can see kind of a trend here, and it goes back to what we talked about earlier. The military will do anything for the greater good, while medicine values the individual patient. As bioethics scholar John Moskop says, the physician's decision to enter military service is a morally weighty one that bears reflection on the practice of the military service to which one is pledging obedience. The moral reality is that physicians lack enough training and education to reflect. The ethical dilemmas they face need to be an open debate in a larger context for overall better outcomes. And by watching this video, you become part of this debate, armed with basic knowledge of medical military ethics.